I want to ask you something that almost nobody asks. When something goes wrong in the operating theater, a complication, an unexpected bleed, a moment where the surgeon has to stop and think, what is actually going through the surgeon's head? Most patients assume it's calm in there, clinical, controlled. The surgeon's been trained for this. They have seen it before, they're fine. And most surgeons, if you ask them, will say something like, I stay focused, I deal with it. That's what you do. And that's true in a way. In the moment, yes, you have to function. But I'm a surgeon and a psychiatrist, and I have spent decades on both sides of this, inside operating theaters and inside the minds of surgeons who are quietly breaking down long before the theater lights go off. So today, I want to tell you what actually happens, not the official version, the real one. My name is Dr. Uttam Shiralkar. I worked as a surgeon for 15 years in India, in the UK, and in the USA. Then a car accident ended that surgical career, and I became a psychiatrist. And eventually, a surgical performance coach working with surgeons on the part of their work that nobody in the training ever touched. I have been inside the operating theater when things went wrong. I have been the surgeon standing there, hands still working, while something else was happening inside my chest that I had no language for at that time. And I have also sat across from surgeons, experienced, respected surgeons who have never told anyone what I'm about to tell you. Let me tell you about a night I remember very clearly. It was a procedure I had done many times by any measures, and then something unexpected happened. Not catastrophic. The patient was fine ultimately, but it required a second operation. More time, more recovery for them. And afterwards, I did what most surgeons do. I wrote up the notes, I spoke to the family carefully, clinically. I went home. The next morning, I was back in the theater, smiling in the corridors, answering questions, operating. But inside my head, for weeks after that, I was replaying that operation on a loop. Every decision, every moment I could have done something differently. The look on the family's face when I explained what had happened. The thought, completely irrational but completely real to me, that everyone in the hospital knew about it and was talking about it. I didn't sleep well for weeks. I didn't tell anyone, not a colleague, not a friend, nobody. Because in the surgery, culture is very clear, even if nobody says about out loud. You deal with it, you move on, and you don't show that it has affected you. That surgeon was me. What I went through after becoming psychiatrist, I found out that what I went through has a name. It's called second victim syndrome. And when I eventually came across the research on it, years later as a psychiatrist, I was almost relieved because it meant I wasn't weak. I was just human. And I wasn't alone. The numbers, when you actually look at them, are remarkable. After a serious surgical complication, more than 90% of surgeons report intense worry and guilt about their patient. Nearly two-thirds report sustained anxiety. Over a third, 36% to be specific, shows signs of acute traumatic stress. Not stress as in a bad day, traumatic stress, the kind you associate with accidents and emergencies. And in a major review published in the British Journal of Surgery, complications were found to more than double the risk of surgeon developing clinical depression within 3 months. Now, think about the junior end of surgery, the residents, the trainees, the people at the beginning of their careers. 86% of surgical residents reported significant emotional distress after being involved in an adverse event. And only 24%, approximately 1 in 4, received any kind of support. 3 out of every junior doctors who experienced a serious complication were left to handle it completely alone. And the reason this is not just a welfare story, the reason every patient should care about this is what sustained distress does to a surgeon's performance in the theater. Here is the part of this conversation that surgical organizations are still not entirely comfortable having. A large study reviewing over 5,000 surgical procedures found that more than half of adverse events involved human error. Not a technical failure, not a drug error, human error. And within that category, the majority were what researchers call cognitive error, failure of attention, thinking error, cognitive bias, missing something that under different circumstances would have been caught or attended. In other words, the surgeon's brain was not working optimally in that moment. Now, what degrades a surgeon's cognitive performance, surgeon's thinking? Fatigue. Operating at hour 20 of a long shift. Distraction, a loud theater, equipment problems, interruptions that break concentration. Also, anxiety carried in from previous case or from something happening at home. And this one is important, the unprocessed emotional weight of the last complication. There is a study that showed simply asking a surgeon to speak while operating, just a conversation, significantly degraded technical performance. Look, the human brain has limited capacity. And when emotional distress is already filling a large part of it, there is very less left for the scalpel. By the way, this is not about blaming surgeons. I want to be very clear about that. This is about understanding that the fiction of emotional invincibility of emotionally untouched surgeon is not protecting anyone. It is actively making surgery less safe. I think about this in 3 directions. From hospital and training programs, the support after a complication cannot be a poster on a wall or a phone number in a handbook. Surgeons who receive genuine, structured support after adverse event recover better, return to full performance faster, and the data shows make fewer errors subsequently. That should be reason enough to take this seriously, even if you don't care about surgeons' well-being for its own sake. For surgeons, especially those earlier in their careers, I want to say something directly. The ones who handle pressure best are not the ones who feel nothing. They're the ones who have learned to acknowledge what they feel, process it properly, and then perform. That is a skill. And it can be learned, but only if you stop pretending the feeling doesn't exist there. And for the patients and families, this understanding is not meant to frighten you. Knowing this makes you more informed, more compassionate participant in your own care. If your operation is elective and you have sensed that something is off with the surgeon's focus, with the atmosphere, you are allowed to ask questions. You are allowed to say you would like to wait. And if a complication does happen to you, know that your surgeon is almost certainly suffering too. That doesn't mean it's acceptable. It just means the conversation afterwards, if you can, is worth having. Remember, surgery is one of the most intimate things one human being can do for another. A stranger, trusting you completely under anesthesia, handing you their body and their life. That relationship deserves honesty, not just performance. We owe patients the truth about what happens in that theater, including what happens inside the surgeon's head. In my next video, I'm going to bring this all together and give you something practical, a proper mental preparation guide before surgery. Not vague advice, not positive thinking slogans, specific evidence based steps that a surgeon and psychiatrist would give to their own family members. Share this with a doctor you know, share it with a trainee, or with a patient who thinks that complication only happen to unlucky people. I'm Dr. Uttam Shiralkar, surgeon, psychiatrist, and a surgical performance coach. See you in the next one.